to Stump the Chump. I'm Lance Luttrell, and this is
Breanna Lathrop.
Yeah, and we're glad that you're here. And a little bit of a joke here, but it's kind of true that you are as much our presenters as we are, all right? Because what we want this time to be is, well, first when I pitched the idea to Rick, I said, you know, when I would come to these conferences, I felt like I had things that I wanted answers to. And what that looked like a lot of times was trying to grab people in the hallway or trying to get meals with them and things like that. And so I said, you know what would be great is if we just had a forum where we just asked our questions. And he said, great. Why don't you be the chump? We'll stump the chump. It's like, okay, great. But then I had a wonderful counterpart here. And so I said, I don't feel as good just being, you know, I was willing to be the chump. So we can stump the chump and we can test the best here, okay? So by way of introduction, my name is Lance Luttrell. I have worked at an FQHC, Christ Community Health Services in Memphis for about 10 years. I was the chief operating officer there. I'm an industrial engineer by training. I was a math teacher for a little while and have been a part of CCHF since my first day. So my first day at Christ Community was actually at a CCHF conference. I'm now healthcare consulting, largely in operations and compliance for FQHCs, but also team building, strategic planning, that kind of thing. And then serve with my wonderful team from Augusta. I've been at Christ Community Health Services Augusta for the last year as the interim CEO, and they've got a new CEO starting on Monday. So I'll let Breanna introduce herself as well.
Awesome. Well, I'm Breanna, and I'm from Atlanta, Georgia. I am the CEO of Good Samaritan Health Center, and this month is my 15th year at Good Sam. I am a family nurse practitioner, and I continue to see patients about half my time. I moved from full-time patient care to medical services director to COO and now CEO. We are a charitable care clinic, so a little different. I think part of pairing us together was also to have two different models of care. We are hybrid in that our clinic does accept some private insurance, Medicaid, Medicare, but 85% of our patient population is uninsured. All my background, including the clinic before Good Sam, has been in the free and charitable sector. I do a little bit of consulting on the side, primarily around equity and social determinants of health and incorporating that, and also how to speak about that in non-healthcare settings.
All right, so here are going to be our rules of engagement. Number one, you can't ask any questions we don't know the answers to, okay? No, seriously, this is very much meant to be an interactive time for us, and as you've heard in different places, one of the beauties of the conference is really connecting with each other. And so what we want to do in this time is we're going to open the floor, and so just when you're getting ready to ask a question, it'd just be helpful for you to introduce yourself, tell us which clinic you're from, kind of tell us which type. If you'd like to direct the question to me or to Breanna, just let us know, but we'll also try to chime in on who we think has the expertise for that. All right, so now the floor is yours. This is why we came here. We'll see what you guys have. The only thing we didn't get here, we're the fruit and things to throw at us when we didn't get the answers right that I'm seeing. All right. Yes, ma'am. So for the sake of just kind of making sure everybody heard that, basically, given current administration and trends, we think FQHCs will need to change how we address and take care of undocumented individuals. Yeah. So I'll take a first stab at that. So I think that what we know is that there have been clear indications from the current federal administration that is going to, specifically look at federal funding being reduced for individuals who are providing benefits to undocumented individuals. However, the 330 statute of the Public Health Service, actually created federally qualified health centers, actually requires us to see anyone in our service area full stop. And so the legislative mandate would actually take precedent over an executive order to that piece of it. And so I think we are still required to see anyone who presents at our clinic. I think the nuance of that a little bit, though, is thinking about, as our organizations, and as I'm trying to walk through this as well, is thinking we need to come back and remember who we are and what we're about. And that's going to guide us in terms of what issues we want to stand on and what issues are matters of nuance and skill and how we present those things. So what I mean by that is, like, in our marketing materials, being very clear about the inclusive of anyone who presents. Because our role as a healthcare organization is to provide healthcare, and it isn't necessarily immigration advocacy or what those look like. We want to take care of whoever's in our community. And so that's kind of my hunch on that, is being skilled at how we present ourselves publicly and like what our messaging looks like, But it seems to me through, what created FQHCs that would still be a requirement for us to see those individuals. Yeah, it's good. Also, I'll come here in a second, but just in the cadence of us doing these things, if there are people who want to comment in on other discussion, we'd, welcome that. But go ahead, sir.
That's a great question. So I think partly for us is that from opening, we accepted Medicaid because pediatrics has been a part of our clinic. In Georgia, certainly where we're a non-expanded state. And so where the bulk of our Medicaid is coming from is our pediatric population. Interestingly enough, the other space that we see a lot of insured patients is in our outreach to people experiencing homelessness. Some of them have Medicaid because of being on disability, and a lot of them, and we can have a whole separate discussion on this, have been put into some of these. In Atlanta, it's been a lot of Oscar, for example, a lot of these insurance plans that without their information, and sometimes not actually correctly done. There's a lot of proprietary kind of calling and saying, I can get you free insurance. Many of those patients of ours, cannot afford any type of copay. And so when they are at another clinic that might accept their insurance, there's no flexibility to be able to waive that copay or work with them. So we've seen it very much as part of our mission to say, one of the things that we can bring to the table is an amount of flexibility, that there are some folks that show up as looking insured, but might as well not be. And in fact, in some of these cases would be better off if they weren't in terms of the type of access they could have. What we have done to kind of balance that is I think the big loss of moving that direction is that, as soon as you're billing, there's certain kind of benefits that you can sometimes lose. Like your EMR, if you were able to get that free, it's not free anymore. If you were some of the states that you can get the malpractice for providers for free, we don't get that for free anymore. So those have actually been the more major budget decisions. We have one person on staff that does billing, and we've done just a lot around trying to, our goal is not to bill for the maximum because there's no matching funding coming in. But we say, hey, anything that we're billing offsets a little bit more of what we can do for the community at large. And so what we've done is really be savvy about what can we bill for consistently, quickly, easily, with good provider training, with we call it a super bill. Like we've created our billing tab to be very click these buttons. Is that maximizing our income from insurance? No. But it allows us to make sure we are accessible to our pediatric population and the population we see that are experiencing homelessness that otherwise really wouldn't have a place to go for healthcare in the community.
Yes, sir. So the question is, both from a free and charitable or hybrid type clinic and from an FQHC, what's the return on investment for engaging donors as a part of overall supporting the mission and what that looks like? You want to take it first?
So 80% of our budget is fundraised and 20% of our budget comes from reimbursement or patients paying on a sliding scale fee. And I think that's probably somewhat similar to most of us in this sector, meaning that where we are getting that money is everything to stay open. The first point of most importance, I think, is the diversification of your funding streams. You don't want to have all of your funding be in any of those categories. When we make our budget for the year, we also make a fundraising plan that includes who are the consistent donors that we go back to, where are the lapsed donors and what's going to be our targeted outreach, where are the grants that are strong and renewable, where are the grants that already told us they are going away and who do we replace them with, and then where are the newer streams of revenue that we might be pursuing. We've had now 2 very successful corporate grants, so out of corporate responsibility type of funding mechanisms that were newer to us in these last couple years and have significantly helped generate important operating revenue. I think that when you are consistently building all of that, you're also building the skill sets that look different, right? Donor relationships is much more about that connection and how do people feel connected to your mission? Is there an event that really becomes important in the community? So we do a lot of come and visit with us. There's something about being at the clinic and touring that tends to really connect people in a meaningful way. How do people like to be thanked? In a way that doesn't feel excessive, like money was spent there, but feels personalized and meaningful. And so we're investing in that piece. On the other side, we're saying donors are consistently on the foundation and the grant making side getting a lot more robust in what they're asking for. And so being really consistent about how are we developing our outcomes management programs to make sure that we can report meaningful data, that it's not just enough to say, who did we see, but we need to be able to say, how did health metrics change over time? And can we correlate that to the types of visits and number of visits that people had? And finally, working in partnership, we found that a lot of these larger corporations are under a lot of pressure to start proving that they're doing something with that profit. And they're actually looking for guidance. So we've worked with a few kind of national corporations that really were seeking to say, if we want to be localized and equity focused in what we're funding, what should we measure? What questions should we ask? And I think that sometimes we get so much in the mentality of being on the asking that we forget to assert ourselves as experts in those conversations. And I think that's one place we've really leaned into, is saying, the gift is, whether it's an individual donor or whether it's a large corporation or a foundation, having the approach that says, we get to help you put your money in a place that's going to improve people's lives in a meaningful way. That, like, we're bringing as much to the table as you are with the dollars. So let's have a conversation about what that looks like in terms of reporting and outcomes management.
Yeah, and I would say that just kind of continue that into the FQHC side of things. I would recommend a resource called The Spirituality of Fundraising by Henry Nouwen, because a lot of what Breanna is explaining here is that fundraising is a ministry of inviting people in and loving people well, so that money and wealth do not isolate, nor do they corrupt their hearts, but they give them a way to use the resources God has given them to participate in his work and his kingdom. And so seeing the people behind the dollars is a beautiful part of any nonprofit endeavor. And so beyond just kind of the bottom line of that, that's sort of a philosophical place that I start from, is thinking the role of fundraising has a way of inviting the community into what we're doing. And so what can happen on the FQHC side of things is, as what usually happens, so for the Federally Qualified Health Center, the grant funding plus enhanced reimbursement allows a scale that usually is different than, free and charitable or hybrid partners. But what that can do is it can start to make you think that you can go it alone, which is often not the case. And so there's just an impossible situation that if you've gone it alone and you've done it that way, and then you hire a development director and say, okay, now I need you to go raise $1 million for our health center. It's like, well, that takes a lot of effort to build the relationship, build the trust, build the reputation in the community. And so I think starting with that as a mindset is helpful. I also think from the disciplines in the FQHC side of things, I've tended to want to not budget on the fundraising side of things. So as a fairly qualified health center, I try to hold the expenses to living within what we're getting from patient service revenue and with our federal grant, and then allowing fundraising to go toward patient assistance program or capital expenditures for growth or particular projects is typically how I like to view that, though I'll be honest, it certainly has been a part of our operational budget at both of the places that I've worked as well. Yeah. Wow. Addressing no-show rates. All right. Anybody else got magic bullets on that? I'd love to hear it. Okay. Yeah, that's right. Okay, well, I'm going to just give a litany of things we've tried and their relative success, and I'll just say that these are some of the thorns in the ground, that this is part of the brokenness of our health center, health system. And honestly, I say it's the brokenness. It's also reflective of that we are asking patients to come to us. I mean, there's just a fundamental piece of how this is designed that puts an extra weight on how the model works. But here's some things we tried. We've incentivized. So we've done, particularly on the dental side of things, that we've done, if you've completed your treatment, done a preventive exam and then completed identified treatment, offering a de minimis, like a $5 or $10 Kroger or like grocery gift card or something like that. There's some wisdom in watching, making sure that you're not in violation of like federal kickback rules and promoting the use of federal benefits. But usually if you keep it under, I think it's $50 on an annual basis, that usually that can land. Promoting, like doing an incentive to come and to show up is one thing that we've done. Another thing has been just being rigorous about confirmation side. So the confirmation piece of it goes a lot more on the procedural side of things, and I would say like general primary care. But on the dental, or when we have like a specialist coming in, really making sure and having that conversation up front, right? We're going to do this, we're going to confirm the appointment. If we don't get a confirmation from you, we are going to put a slot next to that, and then you're going to go into a, wait to be seen when there's another opening in the schedule later in the day. Has been another thing that we've tried there. Yeah, those are two ideas that come off the top of mind. What else have you done?
I have a few others that we have explored specifically and only on dental side, because our dental clinic is about as large as our medical clinic. We started holding orientation. We found that people were really overwhelmed by like what is dental care and the process and the paperwork. And so anyone that had registered for that month to start new dental treatment plan, we'd have them come in and they'd meet with some of our dental team and they'd talk them through, this is what you should expect. This is how dental work goes. This is what's scary about it. This is how we make it less scary. We also talked about the wait time. Like, hey, if you miss your first appointment, this is how long the wait list right now for hygiene care, for example. And then we would actually have them fill out their forms and give them their first appointment so that they really left feeling like, okay, I've got all the paperwork on the day of my appointment. All I need to do is manage any anxiety or anything I have around this experience. And that was we were worried that people wouldn't want to come to something extra, and they were highly attended. And there was a lot of just interest in talking through the process and doing the registration with assistants supporting them versus feeling like all of that happened at the initial care. Another way that we have balanced is we reserve acute walk-in spots for dental first thing in the morning, line outside the clinic just about every morning, because that news, we've advertised it and it's spread. And what we've said is that for these specific spots, we will get you out of pain. It does not make you a long-term dental patient necessarily, but we want to make sure that you have a way to avoid the ER for a tooth abscess. What we've then done is use that as a moment to say, hey, we got that tooth extracted, or we've got you on antibiotics. Do you want to learn about what we could do to prevent this or becoming a long-term dental patient? And then using that as another strategy. It both was a way of helping patients that maybe haven't seen dental care as preventative medicine before experience it as such, while making sure that the schedule always filled with some of those acute walk-ins. And then the last thing we did is that we started surveying both on medical and dental. When people no-showed, we'd do a follow-up call just for a short while to collect data on why people no-showed. And then we also implemented a social determinants of health screen at each visit that we continue to do, where we ask questions, including, have you ever missed a visit because of lack of transportation? Found transportation was the number one barrier to not going to appointments. So we now run an Uber Health partnership, and we allocate, currently it's $4,000 a month of our operating budget is spent connecting patients to visits. So if they get a confirmation and the reason they're not going to show tomorrow is because they don't have a ride, they can call. And what's unique about the Uber Health platform is it's actually our staff driven. So our staff sets up the entire ride so that the patient does not need to have the app or enter any credit card information. And that significantly decreased the transportation as a barrier to missed medical appointments. Sure. So the question was to elaborate a little bit more on what a dental orientation works like. It's not billable. Again, in the free and charitable world, the more patients you see, the less money you make. So it's a little bit of a different dynamic there. So we're a little less worried on what's billable as what fills our schedule, because our currency just becomes who are we seeing and the outcomes we're measuring back to our donor base. Usually we would have 20 to 30 people, which is what's a good size to fit in our kind of upstairs education room. And it was led by our main dental assistant coordinator and one dental assistant support. And they had a preset slide deck, or they have, that they go through. Usually there's only about 15 minutes of actual information. Then everybody has their kind of new patient packet. And if they have any questions, we can move and help them. And then as people finish the paperwork, they would be on a computer and they'd be like, thanks so much. And your appointment is this. We already had the appointments laid out. And so it meant that it was really quick for them to say, as soon as someone was done with their paperwork, here's this new patient spot and here's this based on morning or afternoon preference.
That's great. Yeah. So the question is just, basically, how do you make the decision to offer transportation? Does it get overutilized by people once the word gets out? How do you manage the liability? And then what does it look like going internal? Since you're all done, you want to continue on that, and then I'll add some comments.
So specifically, if you're using any kind of a ride share platform, certainly that helps with the liability question, because you're essentially it's not a service that you're directly providing. You're essentially doing the case management piece of connecting people. What we did is, rather than market it, like start putting it out there as a come be our patient, we have transportation, we educated our staff around its availability and utilization. And then as patients gave feedback, like they were scheduling and they told our staff, I need to see if I have a ride. Then our staff would say, we have a way to get you here if that's your barrier. Over time, news still spreads. Patients learn and they tell one another. And that's what we wanted to happen in a controlled fashion. We also have a policy that incorporates some cost sharing so that patients have a portion of the ride that they pay, and then we are covering the rest. And we also do a limitation to any single patient can use that service twice a month, so that we don't, if someone is coming for a regular weekly education course, for example, for a while, or hoping to use it in other capacities, which can happen, it provides kind of a policy we can go back to that help make sure that amount of money that we've reserved each month for the program does last for that month and can be distributed among patients. I will just note that we have a van that we use for transportation for our outreach program, where we actually pick up patients and bring them to the clinic for our walk-in clinic. And that every year when we renew our insurance policy, the number one area that the underwriters are most concerned about and that drives up our cost is that transportation component. So certainly that is a big consideration if you wanted to take on any transportation that was truly driven by your organization. Rideshare does not cause that.
Yeah, so I'll just continue on that. On the rideshare, the one other thing that I've heard from our insurers is some concern about a medical event that might happen while transporting the patient. So the only other thing that we have implemented when we've done that sometimes is just making sure it's for a non-urgent visit, or, making sure that we only use Uber Health when we're actually sending a patient home. If they arrived but couldn't get a ride home, somebody in the clinic's making a visual evaluation that, okay, this person's not having an emergency, and then we'll use that to send them home. From a FQHC side of things, some of the other things to think about is just when you move into the Uber Health side, it does change your Form 5A. You need to add that to column 2. It's a contractual arrangement for transportation. The billing for it, there is a way you could technically, because this is a contractor billing you for the service, you could actually pass that cost through the patient, although that probably defeats the purpose because they might have used it themselves, but you could reduce that rate down to some sort of flat fee that you could pass through and share with them. I will say from personal experience on having run the transportation inside, it's not only most insured or like the thing that dries up the insurance rate, it's also the thing that it's risky. It's just risky, and it does have benefit, but it has tires have been punctured by going over an apartment complex's entryway the wrong way. I've had a van totaled with a patient inside of it. And so there just are some concerns to consider on that. I would say overall, though, where I've had the experiences are just where the volume of transportation was really, really high. It was actually an organization where we were responding to 911 calls with a provider in the emergency response vehicle. So we were going to patients' homes, and then we were trying to do a medical exam on site so that they wouldn't actually be taken to the ER. And then if it was a thought that they needed to go ER, but they didn't need to go by ambulance, we were transporting them in that case. And so that was, I don't know, we were running that 24/7. So just the amount, the volume of rides we were doing is what created that risk that I think may not be the same situation that we're getting into. But that's just from personal experience. I do have some hesitation on that front, that the ride sharing helps put a little bit of distance in between that for us. And I think another thing I wanted to say, but it also sent me down the road of really trying to pressure my Medicaid plans about the fact that they're required to offer a transportation service, but them making it so difficult given the time frame that patients have to schedule ahead of. And so have tried to explore those and then advocate with patients. So in Tennessee, we actually found that the payers, like there is a program by which if a neighbor brings them, they can get reimbursed for that ride. They can get $20 if the neighbor brings them. So it's not, it's not foolproof in that regard, but that was one way that we tried to help educate patients about doing that as well. Okay. Looks like we got about 10 minutes. Let's try to get through a few more questions.
Yes and no. So the question is about if you're in a charitable care clinic and you're heavily reliant on volunteer physicians, which is often the case, what are some ideas around engagement and recruitment? I think that when I'm at like our charitable care conferences, that's got to be the number one question that comes up. So I'll answer from my perspective, but also from some other good answers I've heard in those spaces. But I think that for us, one of the most effective tools has been finding a champion with a volunteer that loves what they do, and then asking them, like, who are your friends? If they're retired, it could even be like, who do you golf with? Who did you used to work with? And what I've found is also helpful is to lay out a very specific need. So I'll say, I really, really need a cardiologist. Who do you know? Who could we talk to? And sometimes being like given that task, like, oh, this clinic is depending on my recommendation to look within my network for the cardiologist. Then I can call up Dr. So-and-so and say, hey, your buddy so-and-so gave me your name. Do you know anyone that might be willing to do this? I think it's also just showing up in spaces. Anytime I'm anywhere, I'm like asking if it's a medical conference, like, ooh, where do you work? What do you do? And I have found that a lot of people just haven't even had the bandwidth to think about volunteering. But when you're like face to face with someone, often there's a little bit of just disillusionment with healthcare right now. And I think that it's a really great space to connect with that. So sometimes I'll start the conversation with just like, do you want to see a different way of thinking about healthcare? Do you want to escape once a month for half a day? Come tour with me, like sit down and see what this is like. And I found that a lot of people want that invitation. And then when they're there, it starts to feel a lot more possible to like allocate some time.
Yeah. Thanks for answering that. Like, and you're hitting on something that's like very real as I hand the keys over on Monday for somebody else. Yeah. And I think, so the biggest thing that has struck me is like, that is what has just doubled down my efforts of investing in the board of directors. And I know it's not the board should be investing in the board, but it has helped, like you carry that role. They're a volunteer board of directors and doing that, but it has made me just double down on educating and providing resources for the board and really thinking about this is who the organization belongs to in as much of a sense as that is, can be said. And just really, really discusses that. So there have been some very tangible things that I've thought through, like the organization I'm at now, the bylaws give board members a 3-year term they can serve to and then have to rotate off. But the board officers only serve 1-year terms. And that has been, so in my 1 year, all the work that I've done with helping, this is what we should do is gone. And so as I'm handing the keys over, I'm going, man, we're going to make it. I know we're going to make it, but that's a loss, that's a loss there. So thinking about, okay, how do I help my officers rotate on a more reasonable basis so that there's some continuity there? It also, I guess the summary of it is actually look around the CEOs. Board up here, and then actually like executive assistant, or if there are these key members around, like wanting to invest in those roles and really help document, hey, this is how we have worked together, but this is sort of what somebody in this role would be expecting coming in for you. These are the kind of needs that they would be that you should be anticipating and should be looking at for that. Yeah, and then maybe pivoting to the search itself. Yeah, so the organization that we're using did engage an outside search firm, and I think they did a great job, honestly. I think that the search firm helps do this. They help make it a more real process for everybody involved, even though sometimes it feels a little stilted because it's like it got formalized more than our culture feels like it is. But I do think that was helpful in the end. I think that if I could do it over again, I would have leaned into more of the knowledge that I have face selection and alignment. I think we got a candidate that really is there, but I think there was concern from the search firm standpoint of, well, we can ask for mission alignment, but you can't actually, and it's like, well, actually we have a legal opinion here about being a faith-based organization and what that allows us to do. Not that we're being aggressive and trying to discriminate, but we are able to have our chief executive officer meet certain criteria. So if I could do it over again, I would have had some of that conversation more with, because I explained who we were looking for, but we didn't lean into as much like, hey, this is how we approach hiring on that. But I feel like that's an area you might have some expertise.
Yeah. So I've been a CEO for 3 months now, but I actually was part of the CEO search committee for CCHF, actually. And I say the most important lesson that I took away from that is how important having a process defined before an individual. And I think what really helped, CCHF is doing a national search with a team of people that don't see each other in person very often. And what we had done is really create a plan for how this process will work and who will own this process. And we designated a search committee. And we took that board meeting to really walk through and talk to the board about, if you have concerns about the process, we need to discuss them now so that we don't get to a final candidate and then have someone be like, well, wait, I wasn't on the search committee, but I have, all of these opinions and we need to start over. And I think that really helped to have that early alignment around a process and the who owned what piece and how it would go, and a process for what the board would receive in terms of communication and how often. That meant that as we worked through that process, that it was cohesion. And I think that is often where search processes can become really painful, is when there's groups that aren't aligned on how do we get to that correct individual.
The other thing I'll just remind us is we're all interim. So we all serve, some of us are long-term interim and some of us are short-term interim. But there is a helpful reminder for us that we don't always want to tend to things like our wills and what's going to happen after us. But it is so helpful for the people to come after us, for there to be some charted, trustworthy process for that, and do our best to document, here's what I'm doing. So I've been afforded, a 1 year time horizon. It's like I see the end the whole time, but I think it's helpful for us to keep the end in mind for all of us too. All right, maybe one more question if there's one. Oh, wow. Phew, I was like, that went so fast. I talked way longer than I thought. All right. There was an extra zero behind that. Okay, good. Okay, good. Okay, thank you. Yeah, go ahead.
So the question is, this is coming from a charitable care clinic that has both staff and volunteers, and trying to decide when you need to add more support staff or more administrative staff. So I think there are two things that I specifically benchmark. The first, on a clinical side, are my providers being slowed down by tasks that could be done just as well by someone that was trained as a medical assistant or a social worker or case manager or a community health worker? And if I'm feeling like that our volume and our ability to meet our mission and care for patients is at the point of restriction because providers are overwhelmed doing some tasks that could be handed off, that's my indication that it's time for more clinical support staff. On the administration side, and again, because the uniqueness of our sector is the importance and the necessity of fundraising, is that if I feel like we are saying no to fundraising or grant opportunities because we don't have the expertise to do the kind of outcome management required, the reporting, the searching to find new donor sources, that is the number one or the first indicator that administratively we need to be building that core.
All right, I'm going to give you the industrial engineer and math professor answer here. Okay, so what I tend to do is I start with what is my provider capacity. I translate that into like a number of full-time equivalents. So, here's my FTE. And then I have a series of ratios down the whole organization. For one FTE provider, you get 1 MA, you get 0.5 of a nurse, you get 0.25 of a front desk, you get 0.25 of a referral coordinator, just down the road. And now some of those are site dependent and not provider dependent. Like, for example, like a lab, tech, I don't need one of those for each provider. I need one for a site. Billing staff, I try to identify which are the areas. And so as my volunteer pool increases and I have more, full-time equivalent providers, then I've got to understand that cost comes with it too. The industrial engineer side of it would be like also looking, kind of employing the idea of like a theory of constraints. And I think that's what Breanna was kind of saying, my nerdy language is that, but it's like, where are we getting stuck? Where is it that, and honestly, at the end of the day, like if I think about the process of a patient getting scheduled to being registered, to triage, to seeing, like everybody has to go through the provider. currently. I don't know. There may be nurse visits or other things that don't need that, but that's really, at the end of the day, that's where my constraint is. And so then is it defined, if it's seeing somewhere else in that workflow that it's not the provider that's flowing down, that's where I'm saying, okay, I need either retraining, I need to look at that workflow, or I need to add capacity to that area. Yeah.
I learned that I should hire an industrial engineer. So we all learned something today.
Right.
This is great.
That's right. That's great. Yes, ma'am. So the question is, specifically in a federally funded environment, how do you uphold your Christian identity and culture, specifically through hiring practices, and what does that look like? Yeah. So I will say, even at CCHF, that there is a spectrum of an answer to that question. And so I'll give you the Myron Glick, Jericho Road answer first, which is what he says is he will draw a heart and he'll say, here's the heart of Jericho. Here's who we are and here's what we do. What I need to know is, are you headed toward this or are you headed away from this? So he has a much more broader sense in who he's inviting into the organization, because he is convinced that the key leadership of the organization is holding these core values. And so may even, maybe invite some non-Christians into the organizations who are headed this way as a part of their ministry and a part of what they're doing. And then I would say on the other end of the spectrum, you'd have some of the places that, like what we did at Christ Community in Memphis, is we were just very clear in the job posting. This is who we are. We're expecting everybody, and put our mission statement there, which clearly stated it. We had a question on our job application part where we said, want you to express, how does the mission statement resonate with you? Tell me, what does it look like in your, in your professional and personal life to uphold this mission? We trained our managers on how to try to ask that question and hear those answers. And then I tried to emulate the Bruce Miller strategy at Lawndale, which was have the final interview with everyone. I learned really quickly I have a very bad batting average, so I wasn't really sure I was that useful in that last step. It did help me meet the folks, but I'm not really sure I did a great job of vetting that. I do think that there are a lot of health centers that are unaware of the freedoms and the liberty that they do have on this front. And so there are some like state by state part of that, and there is getting a legal opinion for your own clinic. But in every one that I've worked in, or if I've had this role, I've asked us to get advice or an opinion from our legal counsel on this front. And in every one of them, they have reiterated that as a religious organization, we do have the ability to select individuals that align with our values. And there's even case law that backs that up, where that has been upheld. Now, it usually correlates with making sure that upholding those mission and vision and values really align with the job description that's there. So it is much easier to defend, for example, the selection of a CEO, a provider, upper management board who really are responsible for upholding those than it would be to say, if that is an expectation of an entry-level position in the organization. Now, the other thing that our legal counsel has provided us is, if this is a part of their job description, this is what you're doing. So what is it about their role that you're expecting them to embody and to actually uphold? Are you expecting them to pray with individuals? Are you expecting them to not only participate in devotions or help lead devotions? Are there times when there is a way that they don't just need to be a recipient of some of that culture, but they need to be ones who are actually sharing it and putting it out there? And so going as far as to actually putting a line in the job description that says, here's what's expected of you to uphold this in this way, makes it clear from the hiring process to do that. I don't know, Breanna, you have anything else to add on that front?
I would just emphasize from a practical standpoint of doing a lot of the interviewing, the mission question is often the most helpful gateway for me into that conversation. So I'll actually recite our mission statement, which is spreading Christ's love through quality healthcare to those in need, to the individual. And then I'll ask them, tell me what this mission statement means to you. Tell me how you would think about living out this mission statement with us. It becomes an open-ended question that then engages that conversation versus is this mission statement okay with you? Easy to say, yep, and move on to the next one. And then the second piece that is really helpful is, because we do a daily devotion, I describe what our daily devotion looks like and how we take turns leading it. And then I'll say, what are your thoughts on that? Have you ever been involved in anything like that before? What support would you need to feel like you would be successful in leading a devotion when your name comes up? And I've found that's been a really helpful entry point to those conversations in a way that can be less threatening. And for me, the other thing I have worked on really hard in leadership is to also check the bias I carry into those questions, that the language I was raised with to understand Christianity is not the same across all cultures or languages. And so really taking a posture of hearing people describe their relationship with God in the words that are their language and their lived experience. And I think that's an area I continue to spend a lot of time working on and praying on, is how do I make sure that I am receiving their heart toward this mission, even if the verbiage used or the language used might be different than my understanding or my upbringing in Christianity.
Yeah, and I think on that too, trying to think through what are the kinds of answers that would reflect who you're looking for. Taking the time to think about, if I just ask this open-ended question, what does this mission mean to you? Not trying to say out the script of what this looks like, but sometimes I had gone that far, and then I would just hear the answer, and I'd be like, well, that is an answer. Am I now judging this person's faith and like where I'm at? And so trying to come back to like, okay, but the like home run answers sounded like this, or their body language when they answered looked like this. And trying to like over time try to do the pattern recognition of like, okay, the people who have held this kind of answered the questions in these ways has been helpful for me. But I think trying to steer away from overly specific questions about like, where do you attend church, or what's your, what are you doing on Sundays? Because I think even those are not the fullness of what we're hoping for. What we're hoping for is people to actually demonstrate the love of Christ to their employees and to their staff. And that is hard to get out in an interview setting. And for the recording, there was a high five. There was a high five in the group over that question. How to help an asynchronous group of volunteers have, the same information at the same time. Yeah, you want to take a stab at that?
Sure. So a couple of things that have been successful to us. Similarly, although we're larger in size now, that's exactly how we started. And we have a satellite. And so even if you're a larger clinic, your problem may be that not that there's so many, only a few people, but that there's so many sites and they don't overlap. Staff meeting that we do coordinate everyone's schedule to be paid during that time to come. And it's one Wednesday afternoon a month, and it's set, and it is in person. And we like close the satellite, for example, and get everybody together. I found that to be really helpful. The other thing that I have started doing as we've grown and opened a satellite specifically is doing a monthly recap email about like what were the highs, what was new, what are some new faces. I include like shout outs, like who did really cool things. Try to make sure that all departments or areas feel like their story is heard in that. But this idea that I try to think through, if I was a staff member and I walked in after being off for a weekend or a week at a conference or on vacation, what would make me feel like disconnected, or what would eat away at my sense of belonging? And that's been really helpful in creating that. Other thing that we have worked on is, as we've planned out those staff meetings, to do a balance of there needs to be some information sharing or training. Like we have to cover OSHA once a year, but we also include times that are just for the benefit of the personal growth of our staff. We've done team building. We even did personal financial literacy. We had one of our funders, one of the banks that we use, actually came and talked to people about like, how do you buy a first house? Their work with our patients necessarily, but they felt like this organization, which is true, is interested in like my well-being and who I am as a person. And I think that also just increases people's buy-in for those months that seem more separated or you feel more disconnected, to have those moments to come back.
That's great. That's good. Yes, sir. Great. So the question is, if you expect 10% cut to Medicaid, what are you going to do now to prepare over the next 6 months for that? Yeah. I'll tell you the things that we're doing, would be what I do in all the other situations. I think number one is I've been in situations where my Medicaid assignment has been greater than the number of Medicaid patients that I'm seeing. So there's part of just making sure that as I'm looking at the roles of assigned members, that I'm actually doing the work to try to engage with those that I haven't seen. and thinking that, there might be some of those that are no longer eligible that I may not have been seeing anyways. I think the second thing is coming back and looking at, there's the two sides of the revenue for seeing Medicaid patients. One is how many I see, and number two is what I get paid when I see them. So trying to make sure that I've done everything I can for having my PPS rate reassessed and making sure that I've done that if I have the opportunity to do that. And then the third is, would have to go back to the drawing board and look at if I'm trying to still make this up from patient service revenue, then my only other levers to play with are how do I increase my Medicare or my commercial patients to offset those losses. So I feel the weight of that question and the reality that is likely one of the things that will happen as Congress moves to try to come to a budget by September, that I fully expect that there will be, and even Dr. Art Jones was here sharing with CEOs and other leaders yesterday that very much expect for, say, work requirements to be introduced or eligibility in some ways to be introduced to reduce the number of folks that are enrolled in Medicaid. So anyways, that's where my head goes on those fronts to try to do that. Okay. I think we just have a couple more minutes. I don't know if there's any last questions. Maybe one last question if there is one. Okay. Well, y'all have been wonderful presenters. Thank you for making this a reality. So thank y'all.